The first I am taking over the post-refractive eyes. Post-refractive means everything, including from LASIK to RK. Few important considerations where you are operating this patient who are undergoing for the cataract surgery for the post-refractive eyes is the IOL selection, IOL power calculation, intraoperative consideration, and post-operative surprise management. Now, consideration IOL power selection. A patient undergone the refractive surgery, whether it is a RK, PRK, LASIK, they have induced a higher order aberrations, and there is some degree of the corneal irregularities. So, all these patients must be evaluated for the topography and aberrometry to evaluate the corneal irregularity and higher order aberrations. If you want to go for a IOL power selection in the multifocality, a patient with a low to early moderate myopic LASIK, usually having the less higher order aberrations, you can go for multifocal in such patients. But a patient who have more than 8 RK cuts or moderate to high LASIK correction, a more chances of higher order aberrations, and avoid multifocal in such patients. For such patients, you can offer the accommodative IOL with some degree of hyperopic surface is always there in any calculation formula. So these patients will be benefited by the accommodative amplitude of the accommodative IOL, but this is nowadays not much recommendable. Asphericity. A negative aspheric lens is preferable when the patient has undergone the LASIK surgery, particularly myopic LASIK surgery, and the RK cuts of the up to 8 because of the positive aspheric cornea. Such patients benefited by the negative aspheric IOL. You calculate the negative positive asphericity, and according to you can titrate with the Technics lens or IQ lens, whatever the IQ value you require. Patient more than 8 RK cuts, very aggressively treated LASIK or presby LASIK or hyperopic LASIK, it's better to keep a zero aspheric rather than a negative aspheric in such patients. Toric IOL. Can we undergo the Toric IOL in such patients? Yes, you can go for under Toric IOL, but you have very good regular cornea and also should not have marked any corneal irregularities. In RK patients or post-hyperopic LASIK, should not attempt to the Toric IOLs. Now, what should be the refractive goal in such patients? All the calculation formulas which is available, there is always a surprise hyperopic post-op hyperopia. So, it's better to have a target of minus 0.75 diopter or minus 0.5 diopter instead of typical minus 0.25 diopter or emmetropia in such patients. Why there is IOL surprise in conventional formula when you are undergoing the post-refractive surgeries? There is change in the asphericity of the cornea, change in the relationship between the anterior and posterior curvature of the cornea, difficulty in the calculating in effective lens position, and change in the refractive index of the cornea. All these factors are responsible for the measurement of inaccurate corneal power and indirectly affects to the effective lens position, and effective lens position is the key criteria of our third generation and fourth generation formulas. To overcome these IOL power calculation problems, there are 3 different ways to calculate these different formulas. One, the patient has a pre-refractive data is available. So certain formulas are made in such a way, they utilize the corneal power which was the pre-existing, and then they consider the effective lens position, and based on the regression analysis, these formulas are made like a clinical history method or phase minus method. Sometimes patient comes to you, they do not have any keratometry readings, but they just tell us, I had minus 4 or minus 10 in my eyes before the surgery. So certain formulas which are made on that the preset cataract data is not available, they modify some fraction of the refractive correction by the refractive surgery. Mascate formula, modified mascate formulas are based on this one. And another one, patient do not have any records. A 5 year or 10 years or 15 years back operated surgery, and they do not have any records. The most commonly used formulas are the Higgs-Cell formulas and Sama's method. So what should we do? So many formulas are there. There is no magic bullet formula. We have to use the Higgs-Cell formula on IOL Master or Lenstar, Holaday formula online. You can use the ASCRS calculator, and the doctor said as the two-bedded care formula, which is also available online on APCRS website. And you calculate all of them and just have a rough idea which is the best possible available reading for us. This is the way ASCRS online calculator is available with us. Feed the data, pre-operative, pre-LASIK data, post-LASIK data which is available with you, existing data of the IOL Master or the whatever the biometry you are using it, and have a formulations available, you can calculate it according to it. This is another one. This is Barrett 2K formula. And this works very well if you have data of the pre-refractive surgery. If you do not have the data of pre-refractive surgery, this formula will not work. Then the post-RK calculations. Post-RK patients are so unstable eye. Sometimes the diurnal fluctuation of 1 to 2 diopter in such patients. So it is important to take the K reading preferably from the OPSCAN or pentacam and take the consideration of the true K power map or the total corneal refractive power map, which is now available in pentacam HR. So this is a new addition in the pentacam to have a good refractive correction power. In post-RK patients, another modality is a two-stage surgery. Do a simple cataract surgery without IOL. On the next day, according to the reflection, put IOL by the spectacle versions formula. Some intraoperative considerations. Prime importance not to affect the LASIK flap or open up the RK flaps. Patient with the less than 8 RK cuts, incision should be kept in between the RK cuts to avoid the RK cuts to open up. And if it is more than 16 cuts, better to operate the scleral tunnel. Some intraoperative consideration, RK marks are so many times obstruct the view of capsular axis. It's better to stain the entire capsule, use the low parameters, low aspiration rate, low border light, and small caliper tip to avoid the excess turbulence. All patients after surgery do the Siddle test on table to see any leaking of the RK wounds. Surprise management is not the talk of this IC. Now take home message, use the topography or aberrometry, must be in all the refractive cases, proper selection of premium IOL, use appropriate formula in ASCRS online calculator for the IOL power calculation, and low parameters during the surgery in post-RK patients. Thanks for your attention.